Okay, so what we're going to be talking about then is early primary repair of congenital heart disease, focusing on the advantages and what I see as a number of current challenges. And presentation is going to take around about 40 minutes or so, so there's plenty of time for us to have questions and discussion after the presentation. This is the structure of what I'm going to be talking about. So we'll look at a history of surgery for congenital heart disease briefly, the advantages of early repair versus two-stage palliation and delayed repair, the factors that are resulting, I think, in early repair being used less frequently today in the current era, and then some ideas about how we can reinvigorate the use of early repair rather than delayed repair. So, right back at the beginning of congenital heart surgery, we go to 1938. So at that point, at Boston Children's, Dr. Robert Gross ligated a patent ductus. And as you know, this is an acyanotic congenital heart condition with a left to right shunt through from the aorta through the persistently patent ductus to the lower pressure pulmonary artery. And what Gross did was really quite simple. He simply placed a ligature around the ductus to eliminate that left to right shunt. This is a photo of Rosemary Sweeney. She was actually Gross's patient. She's pictured here with Dr. Gross, and she used to come along to an annual memorial lecture that I held when I was chief at Boston Children's in the 1990s. Ms. Sweeney would come along and talk about her memory as a 7-year-old girl when she was that first patient who had ligation of a patent ductus. Now, Gross didn't stop with patent ductus. He did quite a bit of background research on coarctations and thought about how he might surgically repair a coarctation. And it was in 1945 that both he and Crawford in Sweden pretty close to simultaneously performed the first coarctation repair. And this was the paper where he reported his first coarctation repair, and he did that in conjunction with Dr. Hufnagel, who was his chief of laboratory research at Boston Children's. And most of the research was looking at how would you replace that segment of excised aorta if it was not possible to pull the two ends together. And he looked at synthetic options, mainly looked at homograft aortas and how you could prepare and sterilize homografts. But fortunately for them and for us in subsequent years, the aorta, particularly in younger children, is very elastic, and it's almost always possible to do an end-to-end anastomosis. Now, just 2 years after coarctation repair, the first of the palliative operations was developed at Johns Hopkins. So this is just 30 or 40 miles from me here in Washington, D.C., in Baltimore. And Alfred Blalock was the first to perform what has become known as the Blalock-Taussig-Thomas shunt. And as you're aware, this is a connection of one of the subclavian arteries to either the right or left pulmonary artery to increase pulmonary blood flow and thereby reduce the amount of cyanosis in somebody with reduced pulmonary blood flow, like somebody with tetralogy. So it doesn't repair, but it palliates and can delay the actual repair procedure. So just a little bit of information about what happened to Dr. Hufnagel. He actually moved here to Washington, to Georgetown University Hospital, and went on to do the first adult heart surgery operation, even though this palliated aortic regurgitation, it was sort of palliative because it wasn't an orthotopic replacement of the actual aortic valve. It was a replacement in the descending aorta. And the reason I mention it, I think it's a good example of how when you're working on a research project like he was in Boston, it's like, how would I put an interposition graft in the aorta? He used exactly that principle in his first aortic valve operation. So it was palliative in the sense that you still had regurgitation through the aortic valve itself, but it reduced all the flow back from the descending aorta by placing this plastic connection that included a valve, but very much like the operations that he was doing with Gross. And he went on to become the chief of surgery and a very well-known figure in Washington, D.C. In 1952, the first open heart operation was undertaken, but it did not involve the use of the heart-lung machine. This was done at the University of Minnesota in Minneapolis by F. John Lewis. And this idea of using hypothermic arrest with surface cooling was taken up by this gentleman who worked closely with Hufnagel. So Edgar Davis is well known at Children's Hospital here in Washington and at Georgetown in Washington, because not only did he do the first ductus ligation and first coarctation repair, but he used the hypothermic arrest technique for multiple patients. So this is how the technique works. You use surface cooling with an ice bath, lower the core temperature to something like 28, 30 degrees Celsius, place the patient on the operating table when their temp is down, and then you can do a sternotomy and do a rapid inflow occlusion repair of something like an ASD, a VSD, something simple, but certainly you don't have enough time, maybe 20 minutes max, not really enough time for doing complex repairs. It really needed the development of the heart-lung machine, and it was in Philadelphia, so just over 100 miles north of us here in Washington, that John Gibbon used the heart-lung machine that he had been doing research on in Boston at Mass General for many years, and the first successful ASD closure using a heart-lung machine was done in 1954. And then in Minnesota, in Minneapolis at the university where Dr. Walt Lillehei was working, and 90 miles away at the Mayo Clinic in Rochester, Minnesota, Dr. John Kirkland. The two of them performed multiple innovative first-time operations, repairing really the whole range of congenital problems of that day using open heart surgery and the heart-lung machine. Now, here in Washington, Dr. Wallace, who worked with Dr. Kirkland, took over the running of Georgetown University, and then you may have heard of Dr. Jim Cox, who did a lot of the early atrial fibrillation surgery. He took over, but this is actually the end of the story for heart surgery at Georgetown, which used to be really quite well known internationally and nationally. And the reason for that is the change that was occurring in the administrative aspects and financial aspects of healthcare in the US. And this is a topic we're going to get back to later in this presentation, because it's having a big impact on how congenital heart surgery is being delivered in the US. So at George Washington University Hospital, That was taken over by a for-profit company, the Universal Health Services. It was previously a university academic hospital, and the Georgetown Hospital was taken over by a non-profit organization called MedStar that moved all its heart surgery to another hospital in Washington, the MedStar Washington Hospital Center, which is right next to Children's Hospital. And the heart surgery at Georgetown was shut down completely, and the program at George Washington was markedly reduced, and the training programs for both those hospitals were eliminated because these hospitals were no longer interested in training. But we'll come back to that story later on in the talk. Let's firstly review what we mean by early primary repair versus delayed and staged repair with initial palliation. So in the 1950s and 60s, there were very good reasons to delay surgery, and that was because of the very damaging effects of early heart-lung machines on infants and newborns. So this is an example of an early heart-lung machine, a disc oxygenator, a massive priming volume with mainly blood. So this is like a whole body transfusion for an infant many, many times over to be exposed to 4 liters of bank blood. Now, industry started to develop oxygenators suitable for infants in the 1970s. This was a Bentley bubble oxygenator that was used in the 1970s. And these early bubble oxygenators have big problems with multiple microemboli, particularly gaseous microemboli. And for a long time, people worked on developing a membrane oxygenator that would separate the gas in the blood phase in the oxygenator. But by the 1980s, there was an oxygenator that was suitable for infants, not for neonates. And it really needed the development of the hollow fiber oxygenator to reduce priming volumes smaller so that you had an oxygenator suitable for neonates. And that came along in the 1990s. And of course, these days, these sort of integrated oxygenators, hollow fiber oxygenator integrated with a heat exchanger, and really much, much smaller prime volumes. So now you're talking the sort of priming volume that is tolerable by a newborn or an infant. But you really didn't want to do surgery when a child was so small back in the days of those big adult oxygenators. Now, the other revolution that came along in the field was the development of prostaglandin E1. That actually came into use when I was just starting my training at Royal Children's Hospital in Melbourne. And it made a huge difference to the management of newborns with critical congenital heart disease. And it was around that time that Sir Brian Barrett-Boys in New Zealand, who actually was the first to report the use of prostaglandin to resuscitate babies and reopen the ductus. So he also was really the first to jump onto the concept of, let's not delay surgery anymore. We can go ahead and do primary repair in early infancy. And that concept was certainly popularized by Dr. Aldo Castaneda. So both these gentlemen were my mentors, and at Boston Children's, Dr. Castaneda started there, having moved from the University of Minnesota, where he worked with Lillehei. And in 1972, he moved to Boston Children's just as Barrett-Boys was beginning to popularize the concept. And the Harvard program at Boston Children's really was a tremendous location to spread the word about the importance of early primary repair. And I've tried to do the same. I've been a disciple of both Dr. Castaneda and Sir Brian Barrabois. And in the first edition of the textbook, chapter 1 is why early primary repair. So early primary repair then is simply to undertake one-stage repair. And if you have symptoms, that needs to be done in the newborn period. If you're prostaglandin dependent, for example, obviously you are symptomatic, and so surgery and repair is done in that newborn period. If you're not symptomatic, then repair, irrespective of what the condition is scheduled electively at a time that's convenient for the family and the surgical program in the first 2 or 3 months of life, irrespective of weight. So let's look at an example. You're all familiar with tetralogy, of course, with its 4 main features: outflow tract obstruction because of crowding of the right ventricular outflow tract, which is secondary to the anterior malalignment of the conal septum. That also results in an anterior malalignment VSD. And of course, you get secondary hypertrophy of the right ventricle, and the aorta, because of that malalignment, partially overlies the right ventricle. And the surgery, when it's done in an infant, involves really just division of a relatively small amount of muscle. You haven't yet developed a lot of the secondary hypertrophy that can massively obstruct the outflow tract. And a pulmonary valvotomy is usually performed of the stenotic pulmonary valve. The large unrestricted, pressure unrestricted VSD, an anterior malalignment VSD, is closed with a patch, and the outflow, which can be small because of that malalignment and crowding, can be enlarged either with separate patches, as shown here, or with a single transannular outflow patch. Autologous pericardium is a good material to use, but there you can see a repair. Delayed and staged repair is defined as follows. So delayed repair, if a hospital follows this strategy, they're likely to say that they prefer to wait until a certain age, say 1 year of age, or a certain weight, both of which are quite arbitrary. Staged repair means that if a child develops symptoms, for example, if they have cyanosis with a degree of cyanosis such that oxygen saturation is less than 80% or so, or certainly if there are cyanotic spells, then you would do an initial palliative procedure like a shunt or an interventional catheter palliation, and once again delay the repair to an arbitrary age or weight. Now, there are a lot of interventional catheter type palliative procedures available today, like ductal stenting, balloon septostomy, or ASD stenting. You can place flow restrictors in the pulmonary arteries. And of course, you can also limit pulmonary blood flow by placing external bands, but that has to be done surgically. What are the advantages of early repair? Well, the most important one is patient survival. Because you're only doing 1 operation instead of 2, you don't have the risks of 2 operations, and you don't have the risks of a period where the child continues to have the underlying anomaly. So they avoid that interim period of medical care in a palliated state. And when you hear people say, well, it's too risky to do early primary repair, we think it's safer to delay surgery. There's been good evidence going back for nearly 40 years. I mean, the circulatory arrest study that I organized with Dr. Jane Newberger back in the 1980s, we had 171 babies, all less than 3 months of age, all with transposition. The arterial switch was a new operation in those days, and we had a 1.8% mortality. And we did a subsequent trial of pH strategy, 1.8% mortality for children with several different anomalies, but all less than 9 months of age, and an even lower mortality for the hematocrit trial performed in the late 1990s. Now, you could argue that in a randomized trial like this, you have certain inclusion and exclusion criteria, like prematurity, for example. You can't enroll very premature babies in a trial like that. So this is a series of consecutive patients operated on at Children's National here in Washington between 2004 and 2019. No patient with tetralogy in that time frame had a shunt. The median age, just over a couple of months. A large number of premature patients. There are a lot of premature patients in Washington and pretty much anywhere in the West these days. A lot had genetic syndromes, 1.2% operative deaths, and really quite satisfactory 10-year survival and freedom from reoperation. So it is possible to do early primary repair early in infancy with excellent outcomes. And there are a lot of other advantages as well for the patient, for the patient's family, and for whoever's paying for the operation. Let's look at the advantages for the myocardium. Congenital anomalies, if you look at all of them, they're pretty much either a ventricular pressure load, a volume load, or cyanosis, or a combination of those. And if you do a palliative operation, you're going to have persistence of that abnormal myocardial loading and oxygen supply. And this is during a phase when the heart itself, the myocardium, is in a critical phase of early development. So in the example of tetralogy, the right ventricle remains at systemic pressure. Because of that big VSD, it's not pressure restrictive. And so you're going to get progressive hypertrophy, fibrosis, and that leads to a stiffer ventricle, worse diastolic function. And that's really the fundamental Achilles heel in somebody late after tetralogy repair. How good is their diastolic function? So the earlier you repair, the more likely you are to have good diastolic function. What about for the brain? Well, when you're born, the brain's actually really ideally suited to go through the stress, including hypoxic and hypoxic ischemic stress that occurs during normal delivery, because you don't have yet a lot of synapses, you don't have a lot of myelin, and you do have a lot of metabolic adaptations in the mitochondria, fetal hemoglobin, and so on, because a fetus develops in quite a low oxygen environment. Those adaptations, which can be really useful during the stressful period around surgery, perioperatively, they're all lost by 4 to 6 months of age. So why deliberately delay surgery to when a child has a more vulnerable brain? You know, really, this one, the psychological and emotional health of the family, I think is as compelling as any of the reasons. I mean, think about what a family, a young couple is told, okay, your baby has tetralogy. It's not going to go away by itself. It must have surgery at some point. But here at this hospital, we prefer to wait until your child is 10 kilos or 1 year. It's safer that way. So that's what we're going to do. Oh, by the way, we might have to operate more urgently before that and do what we call an emergency shunt. If your baby gets blue, really blue, or like gets faints or has what we call these blue spells, and it's most important for you to understand that what could bring these on is if the baby is like crying, like if their diaper is wet or if they're hungry. I mean, imagine how a young family is going to feel confronted with the fact that they might be responsible for the child's brain damage or death unless they prevent their newborn from ever crying until they're a year old, for example. Alternatively, if you do early repair, then you simply say, well, your baby has tetralogy. We'll set up an operation. When is convenient for you and your family? Are all your insurance company issues sorted out? Let's set up a date in a month or two, and we'll go ahead and do the repair at that point. You choose. What would you rather have? The cost is a lot more when you delay repair. It more than doubles the total cost of care because you're doing two equally expensive operations. A shunt costs just as much as a repair operation and when you analyze it, certainly in the US. The cost of care during the interval period is not insignificant. The child's likely to have regular echocardiograms, regular visits to the hospital, and you're going to get more likely distortion of the pulmonary arteries from a shunt, for example, which is going to need more interventional cath procedures. Shunts have a lot of disadvantages. They volume load both ventricles. They result in additional mortality and morbidity risks for the two operations. They add the mortality, morbidity risk of the interval period. They more than double the cost of care. That's been published in many, many studies. And as I say, they cause pulmonary distortion, such as shown here. So this catheter is going through the subclavian artery to the right pulmonary artery, and you can see that there is a stenosis of the right pulmonary artery adjacent to the distal anastomosis. So that is really common. And it's therefore not surprising. Once again, lots of studies have shown if you have a shunt, then it's more likely that you're going to need post-operative interventional procedures. So, I mean, a reasonable question, well, why would anyone do a palliative procedure in 2025? And the fact is a lot of people are. We looked at, it's a national database in the US, the Pediatric Health Information System, and you can look at specific diagnoses like tetralogy. So 821 patients were registered in this database between 2008 and 14. 1/3 of tetralogy patients were shunted, and the mortality was the same for the shunt versus repair, 4% for both. So you effectively doubled the mortality risk by performing a preliminary shunt. Why is this happening? So let's get on to the third phase of this presentation. What are the factors that are increasing the amount of the number of palliative procedures? The most important one is that current databases focus on procedural mortality rather than patient survival, diagnosis-based patient survival. So What do we mean by this? We'll look at an example in just a moment. So I'm sure you're familiar with the ACHSA database. You guys probably have to fill in lots of fields after and before operations for the ACHSA database. In the US, we have the STS database. Now, both of these were set up pre-internet. The ACHSA database actually did integrate a lot of internet functions pretty well. But, you know, they were both set up as research tools to look at risk factors as to how we could improve surgery back in those relatively early years of congenital surgery in the 1990s. And so they were set up so that early mortality, or what I like to call early procedural mortality, or some people call hospital mortality. I mean, the definition is pretty clear cut, as you found out if you've done any studies that you've tried to publish. And the editors will want to know, are you actually talking about death within 30 days of surgery and or death before leaving hospital after surgery? So if you don't leave hospital after surgery, even if your death is 2 months after the operation, then it is still an early procedural mortality. But these databases weren't designed as quality assurance vehicles, which is how they are being used today. And here's an example. So, hypothetical hospital A admits prostaglandin-dependent symptomatic babies, newborns with tetralogy. Let's say there's 10 of them. They will undergo neonatal repair. And let's say this one preemie who's 1,500 grams does okay after the surgery. And this is truly not an uncommon type of situation. The preemie, very susceptible to necrotizing enterocolitis. You're trying to get the baby to grow, giving lots of high calorie density nutrition. They get necrotizing enterocolitis and they can die from that. And you now have a 10% early mortality, and that's considered high. 9 patients are alive at 1 year. Patient survival, 90%. Let's compare that with Hospital B across the road, who also has 10 hypothetical patients, prostaglandin-dependent tetralogy. And this hospital doesn't do early repair. They say, we don't believe in it, it's too dangerous. So they do surgical shunts, this one early death, but following discharge, 2 of the shunted patients, let's say they lost to follow-up or they develop excessive pulmonary blood flow. They die from heart failure, but they're not counted. That's not a procedural early mortality. So there's actually only 7 patients alive to undergo delayed repair. And let's say they have no death with their actual repair of tetralogy. So they have 7 survivors at 1 year versus 9. But when you look at the statistics in the ACHSA database, they have a 6% overall mortality and a 0% mortality specifically for repair of tetralogy. And I can bet you that's going to be on their website. We have 0 mortality for tetralogy repair, even though obviously they have fewer survivors. And it's gotten a lot worse because this is now so much leveraged by public ranking programs like US News and World Report, because they use case volume, total number of cases, so 17 for Hospital B versus 10 for Hospital A, and procedural mortality. And, you know, as much as you'll hear hospital administrators and chiefs of departments say, well, we don't believe in these rankings, you know, they just do these to sell magazines. But the reality is that they do influence staff morale, They influence recruitment and retention. Donors, who are quite important in the US in terms of supporting hospital programs. The PR marketing. This Children's National was #1 in neonatology, and there were constantly banners hanging in our hospital, and publications would use this all the time, that, we're #1 in neonatology, so the marketing program's going to use it. And US hospitals are run by corporate boards, and they are very focused on numbers, because that's how they ran their businesses. And that's really the next factor. This is where we get back to this corporatization of healthcare in the US. The hospitals are being run more and more as businesses, which in some ways, in terms of efficiency, is good. But you have to be very careful what data is being analyzed. It's just like in the sports world. I'm sure you're all very familiar with the way data analytics are being used in all sports, in all sorts of ways, and betting programs, you name it. But data analytics in sports have become very big. It's very big in the corporate world, as has been emphasized. If you look at the New England Journal of Medicine, they've actually had several articles over the summer just gone on healthcare corporatization. And I have to say, it's been a sad evolution for me to watch. When I came from Australia to the US, I used to feel like healthcare delivery was really very egalitarian, much more so than in the Australian system, which, like the British system, had private hospitals and public hospitals. In the US, everybody went into the same hospital, with or without health insurance, no, with government insurance, whatever. But today, things have changed, and it's become very much a business. And so the boards who run hospitals look at the financial disadvantages of early primary repair. I mean, no, they don't specifically understand, unless they've been listening to me talk about the problem, which I've been doing for a while. But they're looking at a total number of cases. Your case numbers are falling relative to hospital X down the road that's doing more cases. And I say, well, they're doing a lot of palliative operations and like falsely boosting. I mean, they're not doing it for that reason. They would tell you they're doing it because it's safer. But there's a lot of perverse incentives. Salaries are even being tied to case volumes, and ICU census is going to be affected. The hospital profit is going to be affected. There are lots of other reasons, but I think another very important one that your group, I'm sure, is very familiar with is that there are a lot of challenges in training the next generation of congenital heart surgeons. And, that goes to the question of how many cases are being given away as teaching cases. In the US, the executives, the administrators are looking, well, how long did Dr. Jonas spend in the operating room to do tetralogy repair this year versus last year versus 5 years ago versus Dr. X versus Dr. Y? So there's a lot of comparative data being looked at, and teaching cases take longer. And right now, unfortunately, that isn't factored in to the discussion about use of resources and time, and also the outcomes. I mean, how long are your patients on bypass? How long do they spend in the intensive care unit? So this real scrutiny of data analytics is working against teaching programs. Fortunately, the third item I have there, the pipeline drying up, I mean, because congenital surgeons have to do initial training in general cardiothoracic surgery, it was becoming unattractive in the US. That started to change in the last few years as the shorter programs like the I6 Integrated 6 program has come along. But shorter training hours, and I know it's 80 hours in the US, but you guys have even shorter hours, and it doesn't allow enough experience. Age visas, it's going to be even tougher for foreign trainees to get into the US, particularly with the current administration in Washington. And the patients are getting to be more challenging. We have more preemies, a lot of smaller patients. In the US, a lot of the accredited programs were shut down. I told you about Georgetown and GW being taken over by corporations. The Uniform Health Services University, that was a military training program for cardiothoracic surgeons. All of those have been eliminated. So there is not a single training program. The city of Washington is about twice as big as Boston. It's about 6.5 million people. And there's not a single training program in Greater Washington. You have to go to Baltimore or to well into Virginia to find an accredited training program in cardiothoracic surgery. So that's part of the pipeline drying up for congenital heart surgeons. And one other factor I think that's threatening early primary repair is the overuse of interventional catheter methods, which I think should be restricted to the very low birth weight population. So when will we move back to early primary repair? What sort of things can we do to get back to an era when things were moving mainly towards early primary repair? And I would say that happened, I talked about how the 50s and 60s, we had a lot of palliative procedures. The 70s was the beginning of early primary repair. By the late 1980s, there was a general belief in the concept of early primary repair, but it's been in the 2000s, in the last 10 to 15 to 20 years, that those various pressures have been building up with corporatization and so on, and the failure of heart surgeons to adapt their databases. So we need to adapt databases to move to what's important to parents and patients. You don't care about procedural success. You just want to have a live, healthy baby and to spend as little amount of time in hospital having as few operations as possible. So we need to measure patient survival, not procedural success. And we need to measure the efficiency of the approach, total number of procedures, total time in hospital. And those should be the higher ranked hospital. Right now, if you look at what's happened to rankings in US hospitals, the hospitals that are ranked at the top are the hospitals that do more palliative procedures. Now, the World Society database, and I'm aware from speaking with Ayush that many of you are familiar with the World Society, and I hope you'll encourage your programs to get involved with the World Society database. It doesn't cost anything, and the World Society database is beginning to work on a patient survival database. Actually, the only countries that have requested this have been in Asia, but we need the deeply entrenched ACHS database and the even more deeply entrenched STS database to begin adapting towards patient survival. So please do encourage your program leaders to think about getting involved in a patient survival database. It's been a hard slog in the US and in Europe. You won't see a lot of countries from Europe or hospitals in the US that have shown any interest in the world database. But like I say, you're the next generation, and I hope that you will appreciate just how important this is. So in conclusion, there really are a ton of advantages for the patient, family, and society of early primary repair of congenital heart anomalies. I believe that delayed and two-stage repair are being used excessively in the current era, and we really need to develop databases that measure the right things rather than staying with the old procedural mortality type databases that really are not appropriate for use as quality assurance vehicles. So that's it. I'm happy to take any questions, and hope you've found that information to be useful.
Thank you so much, Dr. Jonas.
I'll just kick in with a comment. First of all, I would like to thank Dr. Jonas not only for the excellent presentation and really thoughts about this topic, which is very important, but also because he represents a group of surgeons that worked very hard at the very edge of our specialty in the 80s and 90s, and surgeons of my generation now take advantage of the work done by Dr. Jonas. So if we can take to theater a struggling tetralogy fellow patient, which is a couple of months old, with the knowledge that that operation can be done successfully, and it is a full repair, and it can be done for the benefit of the patient, it's just thankful to Dr. Jonas, who took the stand actually to do that for us, and so thank you very much for that, because I think about this many times during my work actually, having had trained by Bill Braun and Yves Lecomte, and I can see actually nearly every day taking advantage of your hard work and taking actually really the hard way. So thank you for that, and thank you again.
Thanks, Antonio. I appreciate that. Thank you.
Yeah, I think we do have a couple of questions already. So from Dr. Adrian Christian, do you think that long-term studies can add more support for single-staged early repair?
You know, that's an important question, because I think it highlights the confusion that a lot of cardiac surgeons, I mean, whenever, and I've been talking about this topic, I tell you, I've heard versions of this talk many times, but there's a bit of a tendency to really overlap the concepts of patient survival and late survival, and those are different things. You really don't have to have long-term follow-up, because when I talk about, well, we should be measuring patient survival, what I'm frequently told is, you know, it's really difficult for us to get long-term follow-up. We really can't do it because a lot of our patients come from long distances, but we're not talking about long-term or late survival. We're talking about patient survival following repair. And that is a key understanding point, is the endpoint, the metric is survival after repair. It's not long-term survival. So you shouldn't get any points for getting survival after a shunt. But your patient is repaired, and now they have completed the key component, the key metric of that database. So you don't need to have 1 year survival or 5 year survival. which are without question more complex in terms of following up, particularly when you have a practice where patient comes from a distance. The key is that you don't get points. You're not hospital B getting a lot of points for doing a lot of palliative procedures. You only get the points when the patient has had a repair. I mean, long-term survival, of course, is important, and you know that's why I presented in the tetralogy numbers that from the paper that we published a year or two ago. You do need information long-term about reintervention rates. I mean, all of these patients coming back for repeat right ventricular outflow tract obstruction operations, a lot of them needing pulmonary valve replacements. But as I say, that's a sort of different story. What we're really interested in is an initial patient survival.
I think that answered it pretty thoroughly. There's been one more. You touched on some challenges facing training in congenital cardiac surgery. How do you think we can improve this for the future?
Well, I guess the education of people looking at those numbers, there surely should be more reward for the attending surgeons, consultant surgeons who are doing the training. Right now, you know, that while the trainees are well aware of the huge effort that's put in by some attendings and consultants versus others, there's no real measurement of that, and there's no real reward for the people who are putting in that work, other than knowing that they're doing the right thing, and the very grateful trainees who are well aware that they've had an excellent mentor. So how exactly you measure that, it's a complicated question, but I really think that's one of the most important factors that is impacting trainee development right now, is that the attending surgeons who do it really aren't recognized for it.
I guess one of my questions would be, when we're doing early repair, it's a lot smaller children. Do you see a role in simulation and helping trainees that way to build kind of attending
Oh,
confidence?
absolutely. No question about it. You know, there are, I mean, I'm sure you've been to meetings, or you will go to meetings where they have wet labs, or labs where you can do arterial switch operations using, for example, 3D modeled hearts. I think there's a huge number of opportunities for simulated training that are much, much better than a few years ago. And you're right. I mean, I haven't really emphasized, it is more difficult technically to do a repair on a newborn versus doing that operation on a child who's a year or two old. And, you know, to some extent, you do have to be trained in a program that is doing that sort of work all the time. On the other hand, you know, any congenital heart program should be doing a good volume of arterial switch operations, which they have to be neonatal operations. They really should be done in the first month or two of life. So any program that is going to survive as a congenital program has to have expertise with neonatal surgery to do the arterial switch at an acceptable level of competence. But, you know, the repair operation for tetralogy, for example, in a child who's a month or two old is different. It's actually easier, frankly, than operating on an older tetralogy. I really dislike, if I went on a mission trip to China or somewhere and they said, oh, we've got an 8-year-old with like very, very severe tetralogy, I was like, oh, yikes, that is going to be really difficult. I mean, sure, the structures are larger, but the right ventricle is so non-compliant. There's a huge amount of secondary hypertrophy. It's actually a much more difficult operation, and the intensive care management afterwards is also much more difficult. So, yeah, you need to be trained in a program that is comfortable and familiar with neonatal repair, and that includes the intensive care team. It's a really big difference between the ICU team that's familiar with looking after older children versus looking after newborns. They need to be expert in neonatal recovery.
Amazing. Thank you. We have a question from Nabil, who's one of our fellows in the UK.
Yeah.
Hi, Dr. Jonas. Amazing
there.
talk.
Thank
As
you.
you said, I'm a resident in congenital cardiac surgery in the UK. And just reflecting on training in the UK, a lot of the hands-on training does happen when you become a junior attending.
Yeah.
And whilst during the fellowship, it is quite hard to get your hands going, but there's just so much to learn in the world of congenital, because similar to the US system, we're trained adult cardiothoracic surgeons, and then we move on to do congenital, and it takes a number of years just to get your head around everything.
Yep.
But my question to you is, I loved how you talked about the different eras and how it evolved. But I'm just reflecting on what my career will be like for the next 20 years. What do you feel is the frontier that we really need to target? Outcomes are excellent. You've talked about excellent outcomes for neonatal surgery with earlier repairs. But what should we as the next generation be focusing on? What's the next frontier we need to take on and try and challenge?
You know, I think one of the most important questions that your generation needs to address is how best to manage the very low birth weight baby. I mean, there are a lot of preemies, as I mentioned, say less than 2 kilos, 1,500, 1,600 grams. And frankly, the best way to manage those kids, whether they should be managed by interventional cath procedures or simply placing them on prostaglandin and waiting for them to grow, which can be very, very difficult, or should you go ahead with a primary repair in a child who's 1,500 grams? That's an area that I think hasn't been well defined, because the world of interventional cath has been evolving pretty rapidly. Just a few years ago, I mean, getting a ductal stent into a baby that was, say, 2.5 kilograms would have been quite impossible. But since you can do those sort of interventional cath procedures, the question is, should you do those procedures? And how do you work out the combined responsibility of patients who are perhaps initially managed by cardiologists and only referred to the surgeons after the cardiologists feel like, well, we can't go any further with our procedures. How do you get the right balance of decision-making between cardiology and cardiac surgery? That's another evolving area that I think needs to be better managed. I mean, in good programs, there's a good balance of teamwork, and those sort of decisions are made in a team approach fashion, but that's not true in many programs. But in the longer term, I mean, honestly, the real breakthroughs are going to occur in the world of genetics. And I mean, in some ways, you'll be putting yourself out of business if you figure out how to use CRISPR to eliminate the genetic basis of congenital heart disease. But that's, when I talk about the very long term of congenital heart surgery, I usually start off by saying there won't be any, because it'll be eliminated by a better understanding of the genetics and learning how to correct the genetic factors that are responsible for congenital heart disease. I think that's a long way off. I think the next 20 years, you're pretty safe.
It doesn't bode well for me considering that's 40 years.
We'll find
Um,
something for you to do, Aish.
We've had a few more questions if you're happy to take them.
Yeah, sure.
One of the questions is, what would be your minimum weight to operate? Because I think that's been an area for debate. Some people say 3 kilos, some people say a bit higher. How do you find the sweet spot?
Oh, definitely not 3 kilo. I mean, you know, it was very, very common. Many of our patients in Washington were between 2 and 2.5 kilos. That's a very common weight, and certainly doing arterial switches and so on in that age range, in that weight range, was not uncommon. You know, the real the problem area, I think, is once you get under about 1,800, 1,900 grams. But once again, this is in a program that's doing, you know, a 3 kilo baby is a good sized baby. But because the program's doing that sort of work all of the time, and everybody from the people doing the, you know, transesophageal echoes with little mini probes and so on. The whole program is focused on working with very small babies. So it's more difficult in centers that are mainly operating on slightly larger kids. I mean, what is feasible, like if you go and visit Dr. Reddy, Dr. Mohan Reddy at UCSF, he's done a lot of babies under 1 kilo. So it is possible to do open heart operations on extremely small patients. One thing I didn't touch on, I have to say, you know, I did a lot of my early training in an era of using circulatory arrest. And I'm a big believer in the advantages of using a very simple system of cannulation. Trying to place multiple cannulas into babies that are about 2 kilos in size, I think is dangerous. You risk compromising the integrity of the superior vena cava, for example. So using a single atrial cannula, a single arterial cannula, cooling down to deep hypothermia, and switching off and doing the key intracardiac parts of the operation under circulatory arrest is definitely the safest way to go. And a lot of my research over the years showed that that is a perfectly safe system, certainly for at least 30, probably 45 minutes. Is really quite safe for a baby who, as I pointed out, is ideally adapted for hypoxia. In the uterus, they were used to having a very, very low oxygen level and low blood flows at times. So they're well adapted for that. So I think that's part of being able to operate on very, very small babies. But the exact number, you know, I don't think you draw an exact number. I mean, what the number I would draw for doing a NORD operation in terms of minimal weight versus doing a VSD closure would be quite different. So it's not a single number.
We have a comment actually from one of the consultants in the UK as well. He's used a few different techniques to reconstruct the neopulmonary arteries in cases of transannular patches, and he's found the most promising one is using the right atrial appendage, and he hopes that that will reduce the recurrence of PVR in the future. He's quite a fan of early primary repair, and he says the issue is that it's easier to harvest the right atrial appendage in a slightly bigger infant. So how would you approach procedures like this? Okay.
Yes, I've seen those reports on reconstructing the pulmonary valve, right? Not the outflows as much
The
as
valve.
the valve itself. And yeah, that looks like a really interesting idea. I think I personally wouldn't use that as the only reason to negate all of the other advantages that we talked about. I think, putting in a shunt so that just so you can use the right atrial appendage to reconstruct the pulmonary valve. I mean, the reality is that a mild degree of stenosis and a mild degree of regurgitation, or even a moderate degree of regurgitation, is extremely well tolerated for many, many years. The reoperation in our series of tetralogies with repair at a month or two of age is really very low. So I think designing an operation to eliminate any pulmonary regurgitation from the newborn period really is overkill.
And I guess it adds on to two of the questions we have here is the trends these days seems to be delaying repairs, especially for patients needing valves or conduits. How do you decide whether to proceed with an early primary repair versus delaying to allow for growth, especially with things that the cardiologist can do, like ductal stents and flow regulators?
Once again, I don't think that's a good enough reason to defer repair. And, I became a great fan of using cryopreserved femoral homografts. Like if you put in a synthetic conduit, a Gore-Tex conduit, or Dacron, heaven forbid Dacron, or any of the xenograft type conduits, bovine jugular vein, and all the rest of it. I was never a fan of any of those things. On the other hand, human femoral vein it has a terrific valve in it, and it's very thin, so it doesn't calcify. And we used to get several years out of femoral vein homografts. So once again, I think the advantage of to delay things simply to reduce the overall number of conduit changes, that you're unlikely to reduce the total number of conduit changes in a patient's growing years. And a conduit change should be a very brief, very minor hospitalization when it is eventually necessary.
Amazing. I think there's one or two last questions, actually. One says, in early repairs of tetralogy of Fallot, is RVOT and RV remodeling significantly improved in your experience? I guess after the overhaul.
You mean by doing early repair?
Yeah. Mm-hmm.
Yeah, well, as I mentioned, I mean, I think ventricular compliance is really important, right ventricular compliance, because you are going to have some degree of regurgitation more than likely at some point. And if you've got a stiff right ventricle, then you're going to have elevated filling pressures. You're going to have an elevated right atrial pressure. So you want a compliant ventricle, and avoiding that secondary right ventricular hypertrophy that results from delaying surgery. If you delay surgery till a child's a year or 10 kilos, they're going to have a thicker, stiffer right ventricle. And if you then have some degree of pulmonary regurgitation, no matter what sort of pulmonary prosthesis, you're going to end up with some PR at some point, and that won't be as well tolerated. So, and in terms of exercise capacity, I mean, great athletes have very compliant ventricles. So, you want to be able to fill a lot without high filling pressures. So you're going to have better function, lower filling pressures if you've got a more compliant ventricle. So by doing the surgery early, you only need to divide a small amount of right ventricular outflow tract muscle, and you don't have to carve out a lot of muscle and make a lot of scar in the RV outflow tract. That also can increase the risk of late arrhythmias. So yeah, right ventricular compliance is really a very important rationale, I think, for going ahead with the early repair of tetralogy.
I think we have one last question, which is, do you think centers can and will change to measuring outcomes more by survival in the long term rather than operative success?
Hello. Yeah, I mean, I think it's going to happen. I think there are a lot of entrenched interests for all sorts of reasons as to why it hasn't happened. But yeah, as I say, there are a couple of countries in Asia that Dr. St. Louis and Dr. Jim Kirkland are working with, who requested that their national database, and another reason for doing this patient survival thing is right now you have parallel universes. You've got the cardiologists saying, okay, we got a procedural database for interventional cath procedures. And that's quite separate from the surgical procedural outcomes. It's like the families don't care what these database. Okay, these guys have a 99% technical success rate. I love that when the interventional cardiologists say we have a technical success rate. The patient went to the operating room for removal of the stent, but we did get it into position. It was there for a little bit, so that was a technical success. They literally do measure that. But it's the combined impact of interventional and surgery and ultimate patient survival to a 2-ventricle in-series circulation, a repaired patient. That's the metric that everybody should be measuring. And it just makes so much sense. I would think it's ultimately going to happen. But like I say, when you look at the revenue generated by databases for societies, there's a lot of financial and entrenched interests as to why it's not happening. But certainly for good ethical and moral reasons, it should happen.
I think we've had another question in the chat. Are you still happy to take? I think it's bringing a lot of discussion, to be honest. This one says, I have a question in relation to complex double outlet right ventricle, where the options are slightly more difficult with root translocation and Rastelli both justified. In the context of these types of patients, where would you place these procedures in terms of early repair?
There's really nothing that can't be done in early infancy. I mean, once again, I wouldn't delay things. There's all sorts of complex arterial switch type operations that can be done in the newborn period, and I personally would figure out an operation that can be done that in the newborn period. And I don't see delaying surgery as or having some very complex operation as a rationale for delaying surgery.
Thank you. I don't think we have any more questions. So just on I guess on a closing note, what would your advice be for people at the start of their careers in congenital heart surgery? Any big takeaway points that you'd say for us to take forward?
Well, I think the obvious points, you do need to get as much practical experience as possible. So, working in a program where you're going to get good teaching, high quality programs. So you really need to do everything you can to get into a top quality program that offers a good volume of patients. And, personally, I've preached for many years about the value of, spending time working overseas, for example. I mean, there are plenty of programs in India and in China where they have thousands and thousands of cases. And I really think there should be more of a rationalization of teaching globally, so that centers that have a lot of cases but don't have enough surgeons can offer experience to trainees for a 6 or 12 month or 2-year fellowship, for example. That should be accredited training. And at the same time, you want to work in an academically high-level program where you're going to get excellent didactic teaching and really learn the key principles. But you do have to, at some point in your training, get exposed to a good volume of doing the actual surgery itself. You know, with an initial basis of simulation and so on, but ultimately, you really got to do a lot of operations to be good at surgery.